Good morning, everyone, and welcome to this week's University of Melbourne Centre for Cancer Research seminar. I'd first like to start by acknowledging the Wurundjeri people of the Kulin Nations, the traditional custodians of the land on which we are based, and pay respect to their elders, past, present and emerging. Today's presenter is Dr. Ryan Hutchinson. Ryan is a postdoctoral fellow within my group. He completed his PhD in 2014 and did his first postdoctoral fellowship at the University of Melbourne Centre for Translational Pathology with Professor Paul Waring. In 2017, he joined Dorevitch Pathology as the head of digital pathology, and in 2019, we're lucky enough to have Ryan join our group, where his research focuses on the tumour microenvironment in colorectal cancer. He develops and applies tissue-based single and multiplex biomarker assays with companion computational pathology approaches to unravel complex patterns within the tumour microenvironment, and correlates this high-dimensional data with clinical and molecular and histopathology data. So I'm going to hand over to Ryan now, and remember we have opportunities for questions at the end. If you want to ask a question, type it into the Q&A tab at the bottom of the Zoom screen. So I'll hand over to you now, Ryan.
Thank you very much, Dan, for the introduction, and thanks, Zoe, for arranging the link. So today I'd like to give an overview of a current project I'm undertaking within Dan's group. We're looking at young onset colorectal cancer, and my role within the project is I'm characterising the tumour microenvironment of young onset colorectal cancer using computational pathology approaches and immunohistochemistry. So just before I start, I'd like to give an overview of some abbreviations I'll use during the talk. So YOCRC is young onset colorectal cancer, which is defined as an individual diagnosed with colorectal cancer below the age of 50 years old. Mismatch repair status, which is an improved tissue agnostic biomarker for immunotherapy eligibility. So here we can see proficient MMR, so the retention of all 4 of the MMR proteins, so MLH1, PMS2, MSH2 and MSH6, whereas we can see in the DMMR you lose 1 or 2 of these proteins. So in this sample we can see it's lost MLH1 and PMS2, so this is the deficient tumour. And the next abbreviation is TIME, so it's the tumour immune microenvironment, or just simply tumour microenvironment and GI gastrointestinal. So the global burden of colorectal cancer is the 3rd most common instance of cancer worldwide, and it's the 2nd highest mortality of all cancers. Whereas, however, in the last 15 to 20 years, the incidence of all gastrointestinal malignancies is increasing in the younger population. Here we can see in 1995 it peaks, and it's been a constant rise since about the year 2000. And this has been highlighted as well also in a recent publication in Lancet, which has shown that the increase of gastrointestinal cancers in the younger population. So here we can see colon and rectum, esophageal, gastric, gallbladder, pancreas. So the incidence of young onset colorectal cancer is increasing. Here we can see Australia on the left is the nation with the 2nd largest increased incidence, behind Korea. And here on the right we can see the age groups of increased young onset colorectal cancer in the 20 to 49-year-old group. So here we have Australia, New Zealand, United Kingdom, America. Whilst on the other side we can see the decrease in the individuals diagnosed with colorectal cancer over 50, whereas here in the bottom, and with nations where colorectal cancer is increasing in both the young adult population and the late onset, the older population. So just a brief background on young onset colorectal cancer that Dan and Mark presented on last month. So epidemiologically, young onset colorectal cancer is the 2nd most common cancer and the 3rd leading cause of mortality in people under the 50 in the US. And it accounts for approximately 10% of all colorectal cancers in Australia. And as I mentioned, the incidence of young onset has been increasing over the last 4 decades. And by 2030, it's expected to rise by 140%, increase by 140%, and this will be driven predominantly by the increased incidence of rectal cancers. So up to about 30% of these cases can be explained by hereditary cancer syndromes such as Lynch, or a strong family history. And clinicopathologically, these individuals are diagnosed at a more advanced stage, so stage 3 and 4, and they tend to be located distally in the left, so distal colon's the left colon, or in the rectum, and these tumours tend to be poorly differentiated and have a higher instances of signet cell morphology. So in the late onset population, approximately 1 to 2% have this signet cell morphology, whilst it's been reported in the literature up to 13% of young onset colorectal cancers can have this signet cell morphology. So our question is, the development of colon cancer, as been shown in by the Vogelgram. So when it initiates from your normal colon to a polyp or adenoma and then invasive carcinoma, at each stage, is it the inflammation? Is it driven by inflammation, changes in the microbiome, or somatic mutations? So we think that there's an interplay within each stage of these 3 entities. And I should say that the vast majority, all of the young onset colorectal cancers are proficient MMR. So as I mentioned, the young onsets are diagnosed at a later stage. So when they're diagnosed, found at stage 0, 1, and 2, surgery is considered curative, and a subset of stage 2, a high-risk stage 2 colon cancer patients are offered chemotherapy. Whereas in stage 3 and 4, the mortality rates increase, with stage 4 having a 5-year survival of approximately 20%. So histopathologically, when we look at the tumour, we're looking at the T stage, the N stage, the M. We look at anatomical features such as grade, budding. We can look at molecular pathways, whether they're DMMR or PMMR. And we could also look at the tumour mutation status, whether they're KRAS or BRAF. But I propose that by looking at this, we don't have an insight of what the in situ landscape, immune landscape is of these patients. So we're really missing significant information. So inflammation is an established hallmark of cancer. So we can have avoiding immune destruction, which is upregulation of immune checkpoints. And we can have tumour promoting inflammation, which is the recruitment of other members of the immune contexture, such as myeloid cells. And these secrete chemokines and cytokines which drive this inflammation. So as I mentioned, inflammation is associated with a wide range of GI cancers, such as, again, the cancers that have been increasing in the young population. So we have chronic pancreatitis associated with higher risk of pancreatic cancer, and inflammatory bowel disease with a higher risk of colorectal cancer. So as I mentioned, the immune contexture is made up of a vast array of immune cells. These can include T cells, B cells, and macrophages. And here we can see the different tumour types that's been characterised using this immune contexture. And we can see blue, if it's high, it's associated with the good prognosis. Green, which is the literature has given conflicting reports, and red, the immune cells are associated with a poor prognosis. And this has been described in detail by the Friedman lab in Paris. So the tumour microenvironment, as I said, is highly heterogeneous with immune cell infiltrates, but we can see there's some degree of organisation. We have the tumour core, we have the invasive margin, and in some instances we have tertiary lymphoid structures, which serves as immune priming sites, and increased number of these follicles is associated with an improved prognosis in a range of cancers, including colorectal cancer. So when we think about in colorectal cancer, there's 2 different populations of colorectal cancer. When we think about interplay with the immune system, with the MSI DMMR, which have a high amount of mutations, are highly immunogenic, have a high increased amount of T cell infiltration, particularly CD8. And this phenotype has been shown to benefit from immune checkpoint inhibitors. Whereas the vast majority of microsatellite stable or proficient MMR have a sparse or absence of immune cell infiltrate, and these have been shown to respond poorly to immune checkpoint blockade. And I should say that as the stages increase, so in stage 2, proficient MMR accounts for about 80% of the tumours. And when we go into stage 4, it's about 96% of tumours are PMMR. So there's an unmet need, not only in the young onset group, but also in the late onset colorectal cancer to identify biomarkers in this proficient MMR category. So proficient MMR colorectal cancer has a highly suppressive or an inherently immunosuppressive tumour microenvironment. And the first, and as I said, in the vogogram, we have the acquisition of Wnt mutations, and the activation of the Wnt pathway is highly immunosuppressive. So this includes mutations in beta-catenin or RNF43 or APC, followed by mutations in the RAS-PA3K signaling pathway. And here we can see such as KRAS and BRAF. And again, these mutations have been shown to limit the infiltration of T cells into the tumour core. We have TGF-beta, so the tumour cell loses the ability, downregulates TGF-beta in the tumour cells, but increases the TGF-beta in the tumour microenvironment, and TGF-beta is highly immunosuppressive. And then finally, we have a mutation in the P53 signaling pathway, and then this. So in the Buchanan lab, in the histology part, Julie and I have worked on developed a workflow where we've developed standardized, validated single-plex immunohistochemistry assays for a range of immune biomarkers, including CD3, CD8, FOXP3, CD68, and PDL1, which I will talk about today. But we do look at other biomarkers too, and this is all performed in an automated manner on the benchmark, Montana benchmark. Next, we scan all our digital slides using a digital slide scanner at university. And then we input it into a state-of-the-art artificial intelligence platform, and we demarcate the tumour core here in red, automatically generate an invasive margin of any width, but we've used the standardized width of 1000 micrometers here in the pale pink. And then we also can detect immune infiltration in the adjacent stroma, normal mucosa, and tertiary lymphoid structures as well. And in this example of the high output of data, so rather than looking at global densities, we can look at patch densities and regional densities, so we can really investigate and interrogate tumour heterogeneity. So just a background in the AI platform that I use, it's cognition network technology, which approximates the human ability to interpret objects, patterns, and context within large data sets. So in this instance, it's digital slides. So this framework extends beyond pixels. So we group pixels together as objects and uses colors, textures, sizes, and spatial relationships to assign pixel groups as individual and hierarchical objects. So if a nuclei is in a gland and it's a malignant gland, it's a tumour cell, so we can enumerate total amount of tumour cells, for example. We can also extract structures and features of interest, and these can be accurately and robustly segmented and classified across a number of slides. So we can batch process these, so it's not one slide at a time. We can, as soon as we've our AI approach developed and validated on the external set, we can apply it across thousands of images. We combine this data output from our AI methods with other approaches such as data mining, machine learning, and this enables the discovery and extraction of new knowledge. And for image-based biomarkers, which is very topical now at the moment, of extracting information from images which isn't readily apparent to the human eye. And this may support further scientific insights, diagnosis, and progress in patient stratification in clinical trials, for example, in the future. So as I said, I've developed this artificial intelligence approach where we annotate individual cells of interest. So currently there's greater than 5,000 or 6,000 cells of individually labeled for this AI approach. We can see here on the left, or IHC approach, where yellow is annotated in tumour cells, or DAB cells are annotated in red. And here, and also on the right, we apply it to H&E images too, because in the H&E we use this to determine or malignant or tumour cell or tumour region detection against stromal regions, and we serially align these sections, and we can extract the information from the same region within all of our slides. So an example of the data that we can extract from our approaches, we can look at functional, such as PDL1 expression, was it in the membrane or cytoplasm. We can look at morphological, so for example, is DAB circular positive cells, are these static immune cells, or elongated positive CD8 cells motile? And if these elongated cells are negative for immune marker, could these be fibroblasts? And then we can also extract spatial interactions, so whether or not tumour cells are interepithelial or peritumoral. We'd extract relationships and distances between all cells within the image and within subpopulations of interest too. So once we've validated these approaches, we applied this to the ongoing ANGELS study, which is applying novel genomic approaches in early onset and suspected Lynch syndrome, colorectal and endometrial cancers. And recruitment started in 2018 and is ongoing. But today, for the interest of time, I'll only focus on young onset colorectal cancer. So this is just an overview of our clinical pathological characteristics of the cohort. To date, we've had 46 patients. So the patients I only included had full surgical resection specimens, so I excluded tumours arising in polyps and biopsy specimens, so we needed a full face resection. That was for this approach. So there's a lot more than 46 recruited, but for this for this part of the study so far, I've filtered it down to 46. And here, as I said, the young onset colorectal cancer is diagnosed at a later stage, and this is what we see in our cohort. And again, the clinical stage is stage 3 and 4. So then when we quantify the immune cell densities across the whole images and stratify it by site, whether it's distal, proximal, or rectal, we can see there are differences between the CD3 densities, but they're not statistically significant, and this could just because of low numbers. And here we can see CD8 as well, different densities. So again, there's no significant difference between the densities within each region of the each site of the colon. And then here we can just show the heterogeneity of the T cells. So CD3 is a pan T cell marker, CD8 is a marker of cytotoxic T cells. This is a subset of CD3. And we correlate the regions. All the immune cells are highly correlated, as what one would expect. But we can see that CD3, so pan T cell infiltration, is highly heterogeneous in the proficient MMR cohort, whereas CD8 appears to be somewhat homogeneous. So as it says, we've developed the Immunoscore platform as designed by Gallon et al. So we, as I showed earlier, we automatically detect the tumour core and generate an invasive margin per tumour, and we calculate an Immunoscore per patient. So with the absence of CD3 and CD8 in both the tumour core and invasive margin, this Immunoscore is 0, and high presence, so above a predefined threshold, is Immunoscore 4, and here we have groups in between 3, 2, and 1. And recently the Immunoscore has been validated in a series of over 2,500 patients worldwide, and this included stages 1, 2, and 3. So Immunoscore by site in young onset colorectal cancer, we can see there's a heterogeneous distribution, but we don't see as much high Immunoscore, which is defined as 3 and 4. And the cohort at Immunoscore 2, so this intermediate group of this intermediate immunity is a prevalent phenotype. We can see it high in distal and proximal. In proximal colon, these are all pMMR, as I said, and these are Immunoscore 1, whereas in proximal colon with dMMR, these would have a higher incidence of Immunoscores 3s and 4s. And here on the right, we can just see it broken down by pie charts of the distribution of the Immunoscores per region, per site in the colon. So in the global validation of the Immunoscore, we can see that again, 50% was Immunoscore 2, the intermediate phenotype, was the most prevalent, followed by Immunoscore 3 in the over 2,500 patients. Whereas in R46, we show also that in the young onset proficient MMR colorectal cancers, that Immunoscore 2 is indeed also the prevalent phenotype, followed by Immunoscore 1, whereas inflamed Immunoscore 3 is lower. And as mentioned, pMMRs do have an immunosuppressive phenotype, so we would expect a lower instance of Immunoscore 3 in this population. And then when we bin Immunoscore by low, as Immunoscore 0 and 1, and intermediate, we can see these are almost identical frequencies, and Immunoscore high remain the smallest group within these pMMR young onset colorectal cancers. So in recent years, the immunoscore or components of the immunoscore, particularly CD8, has been shown to predict response to immunotherapies. So back in 2014, they showed in melanoma that patients with a high CD8 infiltration in the tumour core and the invasive margin was associated with response. And more recently, in the last year, in colorectal cancer, that it's been shown in the proficient MMR subset of metastatic colorectal cancer in this middle paper that 21% of pMMR tumours showed pathological responses. When they looked by immunohistochemistry tumour microenvironment, these tumours had an inflamed phenotype which was similar to a DMMR tumour microenvironment, which is immunoscore 3 and 4. Commonly, it's 3 and 4. And just last month or 2 months ago, the neoadjuvant immunotherapy trial showed that 27% of pMMR tumours, stages 2 and 3, showed pathological responses to immunotherapies. And again, when they looked at the CD3 and CD8, the immunoscore, the responders had an elevated CD3 and CD8 count. So immunoscore could be a predictor of response, and this could give an option to a potential therapy of young onset. If they meet this criteria of a high immunoscore, they could potentially be considered for immunotherapy. So we know that the tumour microenvironment is highly heterogeneous, and it's more than just CD3 and CD8, and that the immunoscore 2 to intermediate can be further broken down into altered and excluded. The intermediate can be broken down into excluded and immunosuppressed. So as I mentioned earlier, we've developed this panel of validated biomarkers of CD3, 8, CD68, FOXP3, and PDL1. So FOXP3 we can use as a surrogate marker for an increased presence of FOXP3. We can use as a surrogate for immune suppression. And a high instance of CD68 we can use as macrophages, which is usually common at the invasive front in the immune excluded phenotype. And usually some studies have shown in other cancers that the excluded phenotypes associated with a higher instance of Wnt mutations such as beta-catenin. So how do we understand this tumour microenvironment heterogeneity, and how can we capture this complexity in a more efficient way? So here we can see a colon cancer, annotated here in blue as an immune cold region, so there's the absence of the immune cell infiltration. And here, when we look at a heat map of this, we can see here there's a small spot of positivity. So sorry, we look at this blue region here, we can see there's an absence of immune cell infiltrate. There's just some stromal cell PDL1 positivity. Whereas in this hotspot, we can see some tumour cells have PDL1 expression on tumour cells, not on immune cells, but on tumour cells. And this, in pMMR colorectal cancers, this is quite seldom occurrence of tumour cell expression. This is linked to underlying mutations such as in BRAF or KRAS. So to address this complexity, we've developed a principle called in situ tissue signatures. And this is defined as these are computationally pathology-derived signatures, and these are descriptors of the whole slide histopathological images rather than selected fields of view, which you get in some scanners or tissue microarrays or TMAs. By adopting this approach, we can interrogate and use all available data within the image, not just selected, pre-selected data. And these signatures are combinations of intra and inter singleplex and or multiplex biomarker readouts. And this enables multivariate and combinatorial biomarker analysis and evaluation beyond conventional eyeballing and global density scores. So here we can see, for example, we can look at our CD8 cells and substratify whether they're PD1 negative or PD1 positive. So are these activated T cells or exhausted T cells? We can look at macrophages, whether they're PD1 positive or PDL1 negative macrophages. And then we can also look in tumour cells to see, are they proliferating tumour cells with Ki67? And then within these proliferated and non-proliferating tumour cells, what's the pattern of PDL1 expression? So this is, again, capturing the global complexity of the microenvironment rather than just relying on a single density readout. So as I said, we're interested in moving beyond the global density, so we've created I've generated immune gradient phenomaps. So this is just an example of 3 tissues scored for CD3. We can see in pink is the highest density, with blue being the absence of CD3 cells, and it goes up in a gradient from green to low to pink is high. So CD3, we can see the heterogeneity across 3 images. When we serially align and then detect CD8, again, we can detect the heterogeneity of CD8 on the global scale, rather than just, again, as I emphasized, not just a single number. We can look at the CD68 distribution within these tissues too. So all of these tissues are aligned, so we can spatially evaluate the spatial interactions between all these individual immune cells. We can look at FOXP3, so we can start to build up we can start to visually see patterns now. We can see with FOXP3s along the invasive margin. So this could be the immune suppressed phenotype. And here we can see, even in the presence of CD8, you don't always have PD-L1 expression. And in other cases where you do have a high incidence of CD8 expression, you do have an increased PD-L1 expression too. So PD-L1 expression can be induced in different ways. So it can be adaptively induced, or it can be intrinsically induced. So adaptively induced is by CD presence of interferon gamma from cytotoxic T cells. And intrinsically induced is driven by tumor mutations within the tumor cell. So when we capture this complexity, we took the immunoscore 2 patients, which was our predominant phenotype, and we ran this through our AI program. So we wanted to classify the immune score 2 only and say, are these immune excluded or are they immunosuppressed? So here we can see that the immunoscore 2 was broken into 2 populations with a higher incidence of immune exclusion phenotype in the immunoscore 2 and a lower incidence of immune suppression. And this is again driven by CD68 at the invasive margin, and this is associated with immune exclusion. And also when we look at PD-L1 at the invasive margin, this is associated with high PD-L1 and immune excluded, and a low PD-L1 immune suppressed phenotype, which is almost similar to immunoscore 0. So even though they're immunoscore 2 now, these patients have a phenotype similar to immunoscore 0. So then when we look, so this was the excluded phenotype, and here when we look at the tumours classified as immune suppressed, we can see that FOXP3 is high at the invasive margin. The median of FOXP3 is high here at the invasive margin compared to the excluded. But again, PD-L1 remains highly overexpressed in the immune excluded group and the immunoscore 3 group, which you would expect because this is an inflamed tumour. So this is just breaking down now, further breaking down the complexity of the tumour microenvironment. So we've now split immunoscore 2 into 2 further subphenotypes. So immune excluded here in green and immune suppressed here in blue. So we can see in distal colon, we've split it in almost 50-50, and then the same in the proximal colon. Whilst in rectal cancers, the predominant phenotype in immunoscore 2 seems to be immune exclusion. So since the immunoscore was first described back in 2006, it's gained a lot of traction in a range of cancers. So here in 2006, we've talked about the type, density, and location of the immune cells, and it's generated an immunoscore. And this then led 5 years later to a editorial which suggested that M is for memory. M should be considered for memory. With the recent global validation of the immunoscore last year, published 2 years ago, the World Health Organization now suggests that the immune response is a desirable diagnostic criteria for colon cancer. So immunoscore has been validated as a prognostic marker in stages 1 to 3 colon cancer. So in summary, we've shown that T cell infiltration is highly heterogeneous in pMMR colon cancer, and this is predominantly driven by CD3. And there is a subset of approximately 20%, which has been described in literature before. We found this an identical 20% in young onset, which have a tumor microenvironment similar to that of dMMR. And left-sided young onset colorectal cancers are inflamed, whereas right-sided tumors tend to be more heterogeneous. And by splitting immunoscore 2 phenotype into the subphenotypes, we're showing underlying biology of these phenotypes in colon cancer, which can be potentially targeted with different combination therapies to overcome this immune exclusion or immune suppression. And we have moved into the multiplex space for not only these biomarkers that I've talked about today in the talk, but we've looked at other biomarkers. This is a poster we presented last year in collaboration with the Finians and Altiview at SITC, where we applied the exact same AI approaches on the multiplex images to further extract more information from the tumor microenvironment. And if you are interested in this poster, I can send a copy through. And I'd just like to thank everybody in the colorectal oncogenomics group. It's been a real team effort to get this data together. I'd like to thank Dan for his supervision and guidance and everyone for their input. I'd just like to thank Michael at the Royal Melbourne and my collaborators at the Finians. I'm happy to take any questions. Thanks very much.
That's great. Thanks very much, Ryan. That was a fantastic presentation. We've got a couple of questions that have popped up here already. And a reminder, if you want to ask, just type it into the Q&A section. So the first one here was from Finn McRae. He wanted to get you to explain what is the difference between immune exclusion and immune suppression again.
Okay, so immune exclusion is where the T-cell infiltrate is kept at the invasive margin, so it cannot penetrate into the tumor core. So it's lined up as a wall at the tumor invasive margin. Whereas immune suppression, we have immune cells there, but they're not active because FOXP3 is downregulating the cytotoxic activity of CD8 cells. And the CD8, the FOXP3 ratio has been shown to be prognostic in a range of cancers. So even though the immune cells are present in immune suppression, they're not functionally active.
Great. So the next question is from Case. Beautiful work, Ryan. There is clearly an important role for tumour microenvironment in the development of proficient mismatch repair colorectal cancer in such young ages. What do you think is driving the etiology behind this trend? Diet, lifestyle, or some unknown environmental agent?
I think there's multiple causes we're looking at in Dan's group. We're looking at Eric's investigating the microbiome, Sherelle's collecting questionnaires to look at lifestyle, and Cleve and Peter and Mark, we're looking at the somatic landscape as well. So I think it's a collection of entities rather than one single driver. I think it requires certainly more research and correlation with tumor microenvironment for sure.
I might just follow up on that, in that you showed that there's differences within the site and the colon and the tumour microenvironment. How much do you think that diet and lifestyle might be influencing those particular immune phenotypes that you've shown?
Well, I think because the colon does have the different sites or sides of the colon has different physiological roles. So certainly, when certain foodstuffs are consumed or alcohol is consumed, certainly it can alter the immune microenvironment too. But there's a lack of data correlating these dietary or these environmental factors that can be modified. These modifiable factors, there's a lack of research in the literature comparing these different entities.
Cool. Next question. Wonderful work. Great to see that the young onset colorectal cancer tumour microenvironment is analysed at such levels. In your phenomaps, will you be capturing stromal cell signatures in the future? Do you have data related to the consensus molecular subtyping for young onset colorectal cancer?
So I should have made it clear that in the phenomaps that these phenotypes are extracted from both the tumour cells, so the malignant glands and the surrounding stroma. So we can visualize these maps separately, but I've just combined both of them together to show the complexity. And it's interesting to point out the CMS we don't have the information on CMS subtypes, but this is certainly something that has been proposed. You can generate using an H&E image alone, so that you can use deep learning approaches to predict the CMS subtypes. And this is something that I am interested in and I've been looking at, but currently at the moment, no, I don't have any information on the CMS subtypes. But there has been some groups in America who've looked at the CMS subtypes that have said that it's in the young onset, the proficient MMR, it's CMS 2, 3, and 4 seems to be the predominant phenotype. CMS 1 is more associated with your DMMR, the Lynch syndrome, or the MLH1 methylated tumours. So CMS 1 is quite rare in young onset colorectal cancer in the PMMR context.
Great. From Michael Christie, outstanding work, Ryan. Do you think the inflammatory bowel disease is related to young onset colorectal cancer?
I think it is, because I think with this chronic inflammation, your immune system has to react to address this chronic inflammation. So I think this is where we start looking at this immunosuppressive phenotype that I've been able to generate. Is this enriched in IBD associated colorectal cancers? This is a hypothesis to test, but currently I don't have any inflammatory bowel related colorectal cancers to investigate if this phenotype has a preponderance in this subset of colon cancer. But it certainly is an interesting question, Michael.
Right. I think Michael's very worried that with your approach, he's not going to have a job in 10 years. So a question from Sean Grimmin. Hi, Ryan. Can I ask about the size of the sections you've used for this work? Are TMA viable for all this sort of immune landscape analysis?
Yeah, so all the sections, the 46 sections I've used to date has been full surgical resections, so full face specimens. But yes, certainly these approaches can be applied to TMAs. There's no limitation the only limitation is in TMAs we can't address the heterogeneity properly or as comprehensively as we can in full face sections. But certainly in TMAs, these approaches can be applied without any issue.
We've got a question. My daughter at 29 was diagnosed with a stage 2 and 1A colorectal carcinoma. We've been told that it was just bad luck. She had a mutant gene. How can your work assist in determining what might be triggering this mutation?
I think that's a question for the whole research community to address rather than just one single. I don't think I can answer that question with this approach.
Do you think your immune profile is going to help to get at the etiology a bit more? I guess it's following up a bit more of Case's question.
I think for when we have whether it's a biopsy or a resection specimen, when we do this immune profiling, it can give us some insights of what the functional orientation of the tumor microenvironment is, and then we can potentially work backwards to see, what is it associated with lifestyle factors associated with genetic mutations. So certainly we can, we can use this approach to profile the tumors and then use it as an integromic, so integrate all omic data, so the tissue phenome and the tissue genome, to integrate this together and look at the modified risk factors to see if there is correlations and links.
And last question from Finn. What is your sense of whether the extended immunoscore that you're doing in young onset colorectal cancer is different in older onset colorectal cancer? Given that the tumours are distal and largely MSS in young onset colorectal cancer, is this telling us why?
Well, currently that's a good question, Finn. I think what we're doing now in the group is I'm getting a control group, so later onset PMMR tumours, and I'm getting some young onset Lynch tumours to compare the distribution of these phenotypes. But yeah, the young onset cancer, I think this intermediate immunoscore, it's been shown to be prevalent in the late onset as shown by the immunoscore validation, but no one's described the immunoscore yet in young onset colorectal cancer. So I think I wanted to move beyond just saying it's immunoscore 2. I wanted to find out reasons why it's immunoscore 2 and why can the immune cells not get into the tumours effectively. So I think using this extended immune panel beyond immunoscore will give us these insights and potential answers in the future when we analyse larger data sets and correlate with clinical outcome and histopathological features and genomic features. So I think it is a work in progress, and I hope to have answers very soon.
Right. Very quickly, very last question from Fred Holland. Is there a relationship between immune exclusion and fibrotic areas and or collagen density?
Well, for the immune exclusion, I did look at for the immune exclusion subset, I identified, I went back to the H&E and then I ran the AI approach again over the H&E image to see if we could detect elongated cells in the invasive margin. So I know it's not an accurate approach for fibroblasts, but I just detect elongated cells. But it seems that elongated cells is enriched in the immune excluded phenotype too. And people have shown that presence of fibroblasts, especially in melanoma and lung cancer, the invasive margin is associated with increased TGF-beta secretion as well. But as I said, I haven't looked at any specific fibroblast markers in this cohort, so I just purely went by morphology-driven H&E approach.
Fantastic. Thanks again. Thanks very much again, Ryan, for a wonderful presentation and answering all those questions. Thanks everyone for attending.